Good evening. Uh, can you hear me? Anybody is there? Please let me know. Yeah, by the time everyone come, we'll. Yeah, we'll recapture what we learned yesterday. Yeah, we were talking about breast surgical anatomy. We are talking about breast surgical anatomy. Yeah, we know that in the chest, the breast extends superiorly from the clavicle up to the inferiorly up to the sixth rib or abdominal rectus fascia. Medially, the lateral border of the sternum, lateral border of the sternum, and laterally up to the anterior or mid axillary line. Yeah, mid axillary line. Yeah, I can. If any doubts are there, you can just use the chat box. Yeah, I can see it. Now, we'll the functional unit, the basic functional unit of breast is terminal duct unit, which is, if you see, terminally the lactiferous duct ends terminally into smaller ducts, which forms a lobule, which is drained by the minor lobular duct, which drains multiple lobules will be there with the terminal duct. Lobule with the terminal duct combinedly called as terminal duct lobular unit, which is the functional unit of the breast. So these lobules, multiple lobules join together to form the lactiferous duct. These lactiferous duct have a widening just before they enter the nipple areolar complex, which is called as ampulla, which enters the nipple areolar complex. Multiple ducts are there. So these lobules together, these multiple lobules together form the lobes. This is lobe, breast lobe, which is drained by a major lactiferous duct. So major lactiferous duct, how many are there? Up to 10 to 100 can be there. 10 to 100 breast lobules will be there. So this is the functional anatomy, and this breast, we'll see how the breast will be there. Posteriorly, it is situated on the pectoralis fascia from clavicle, pectoralis fascia. We have multiple lactiferous duct with ampulla, and we have acinus. So these are the acini. Together, this is called, we just saw lobe. So what I'm telling you here is, the thing is, the skin and the breast parenchyma is held by some thread-like structures or rope-like structures to the pectoralis fascia behind. These are called ligaments of Cooper. These are the supporting structures which hold the breast skin and parenchyma to the pectoral fascia. Okay, behind the pectoral fascia, what we have? We have a pectoralis major muscle. We have pectoralis major muscle. Yes, behind the pectoralis major there is pectoralis minor also, and there is bones. Which bones? Yes, up to sixth rib. Second to sixth rib is our breast. Okay, so this is the surgical anatomy of the breast. So then at the nipple areolar complex, there will be multiple lactiferous ducts opening. Multiple lactiferous ducts opening will be there. Okay, and at the nipple areolar complex there comes two important muscles. One is circular muscles, which is called as sapis muscle, which helps in nipple erection. The other one is longitudinal muscles, also called as Mayer-Holtz muscles, which helps in nipple retraction. Yeah, yesterday I also told how to remember. Yes, circular muscles, sapis, CSE for erection, and longitudinal muscles called as Mayer-Holtz and is for retraction. Yeah, can you people hear? Yeah, my voice is audible, right? Yeah. So let's go forward. Yesterday we also described or discussed about the arterial supply of the breast, which is very important. If this is the breast, yeah, the major supply is derived from the axillary artery. Axillary artery gives two branches, which is thoracoacromial artery, and the branches from the thoracoacromial artery. The other one is lateral thoracic artery, the branches from lateral thoracic artery. Medially we have internal mammary artery, and the branches from that. So we have another laterally, we also have other branches which are from lateral. These are lateral branches of posterior intercostal artery. Yes, this is internal mammary artery. Axillary artery branches, which is thoracoacromial, and lateral thoracic artery. So any doubts in this? Yeah, no. Please let me know if you have any doubts. The next one is lymphatic drainage of the breast. Lymphatic drainage of the breast, which is very important. Yeah, we can lymphatic drainage. We can discuss these among two, that is anatomical drainage and surgical levels of drainage. Anatomical drainage. Yeah, we divide the breast anatomical drainage of the breast into skin over the breast, the nipple areolar complex, and the breast parenchyma. parenchyma. So we discussed nipple areolar, skin over the breast, skin over the breast, the upper outer, lower outer, upper inner, and lower inner quadrants. And we have clavicle. So the lymphatics from the upper outer and the lower outer quadrants, they drain into axillary nodes. Axillary nodes. The inner quadrants, upper inner and lower inner quadrants, drain into internal mammary nodes. The upper inner part, the superior part drains into supraclavicular nodes. So now the nipple areolar complex, they form plexus, multiple plexus around the nipple areola called as Sapis plexus, which in turn drain into axillary lymph nodes. And the breast parenchyma, they drain into corresponding segments of the skin, which into axillary nodes and internal mammary nodes. So this is the anatomical drainage, lymphatic drainage of the breast. Okay. So the surgically how the lymphatics are classified. Surgically they are classified based on the muscle. So there is a muscle named pectoralis minor. So pectoralis minor is there in the axilla, the clavicle. So this is the axilla. So among these, the level 1 nodes, this is pectoralis minor. Pectoralis minor. Anything which is lateral to the pectoralis minor, lateral border of pectoralis minor, are level 1 lymph nodes, which contains the axillary group of lymph nodes, and anything medial to the pectoralis minor forms the level 3 nodes. These levels are also called as Berg's surgical levels, BERGS. Berg's surgical levels of lymph nodes. Anything which is behind the pectoralis minor or level 2 lymph node. This is surgical classification. Now we also discussed about the presentation of the breast disease. Yes, what is the most common symptom? Most common symptom will be lump. Lump in the breast will be the most common symptom, which can also sometimes can be nipple discharge, or it can be sometimes pain. If there is pain, then what are the two conditions you should suspect is, one is infection or there is inflammation. So it can be an abscess or a mastitis. Nipple discharge we discussed in detail yesterday. Yeah, it can be nipple discharge can be single duct or from the multiple duct. Yes, if it is a serous discharge, if it is from the single duct, it can be pregnancy or physiological during puberty, or it can be a malignancy also, or it can be in duct ectasia. it can be duct ectasia also. Or in case of multiple also, it can be pregnancy in case of puberty, or multiple malignancy, or duct ectasia. There is greenish or blackish discharge, green or black discharge, it is most probably due to duct ectasia. Duct ectasia. Okay. If it is bloody discharge, if the discharge is blood, if it is from the single duct, it can be single duct papilloma. Single duct papilloma. Or if it is multiple duct, it can be malignancy. Or it can be also be ectasia, duct ectasia. And if it is milk, yes, we already we know that if it is milk, it can be physiological during lactation, or when there is increased prolactin levels. So this is the picture of nipple discharge. And let's come to the assessment of any breast disease. Assessment of any breast disease. I am just revising yesterday's topics. Assessment. We call it as triple assessment. Triple assessment of breast, which contains clinical examination, radiological examination, and in pathological examination. Okay. Now we will discuss about the clinical examination. Later we will discuss about all the other things. Clinical examination. Okay. We have in clinical examination history and examination. Clinical examination or palpation. In the history, we should talk about the patient's symptoms, like whether the patient having lump, which can be acute or chronic duration or recent onset. So acute probably could be a benign or any infective etiology or inflammatory disease, or if it is a chronic or long duration, it could be due to malignancy also. And we should also talk about the discharge or change in size of the lump, and also the important thing is family history and past history. Past history and family history. We will talk about past history and family history while discussing about malignancy. We will just know here. And examination of the breast, which is very, very important. Examination of the breast. How we examine the breast? One thing, firstly, we inspect the breast. Inspection. Inspection of the breast can be done in three positions. One, supine position, where the breast relax and the pectoralis major muscle, and if there is any lumps or any hard lumps which can be majorly visible, can be appreciated. The other thing is sitting position with hands by the side. Sitting position with hands by the sides. Here you can appreciate whether there is any prominent lump, which when the breast is hanging down by sitting, or the breast, the support tissues which are called ligaments of Cooper, are the muscles which should be kept into contraction. That is sitting position with muscles contracted. That can be by raising the arms above shoulder, or putting the chest muscles, chest wall muscles into contraction. That is, can be serratus anterior and also pectoralis major. And inspect the breast. Okay. So similarly, palpation palpation is done among in this the best position for the NEET examination or NEET PG examination. This could be the question. The best position for examination of breast, yes, it is supine position. Supine position. And the method of palpation is important. Methods of palpation. Which is the best and most commonly used? Yes, anyone? Which is the best and most commonly used method of palpation? Yes, it is dial clock method. Yeah. What are the other methods? Yes, if this is the breast, let's say this is the breast. Okay. What are the methods of palpation? One thing, it can be palpated through zigzag position or horizontal stripes in this direction. Horizontal stripes. Okay. Or it can be in vertical stripes. It can be in vertical stripes. This direction, or it can be circular. It can be circular. It can be circular. Yeah, most of the people in your practicals, we all know, yeah, what we teach is circular motion. How to palpate the breast? Yeah, centrifugally outwards in anti-clockwise direction, using the pulp of your finger. We palpate the breast, which is circular. What is dial clock method? Anyone? Yes, dial clock method is the newer one, or whatever, which is the best method. Yeah, how it is dial clock method? Most of the people think circular method as dial clock method. No, dial clock method is different. How dial clock method is palpation is done is, we just label the breast into the clock positions, that is 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock. We know this 1, 2, 4, 5, 6, 7, 8, 10, and this is clock. So it is palpated with the palmar surface, the pulp of the finger, which is usually only 3 centimeters. Only 3 centimeters should be used. The pulp of the fingers, which covers only about 3 centimeters, that should be used. And how it is palpated? From the 12 o'clock position. From the 12 o'clock position. In the 12 o'clock position, from outside inwards, we say outside inwards means from here you palpate here 3 centimeters palpation here, and the next after that 3 centimeter you palpate 3 centimeter in the 12 o'clock outer position. Next you come half of the first palpated area and the other half of the newer area. Then you should continue towards the nipple areolar complex. Towards the nipple areolar complex in a clockwise motion. Clockwise motion, that is at the 12 o'clock. Next, after that, we palpate at 1 o'clock. We palpate at 1 o'clock. Half of the previously examined area should be covered by the next. Similarly, at 2 o'clock, 3 o'clock in the anti-clockwise direction. This is dial clock method. Dial clock method of palpation. Okay, so this is clinical examination. So next, what is the next is the radiological examination. Radiological examination. Yeah, we discussed clinical examination, which is history and examination part. The best method is dial clock method. The best method of palpation is dial clock method. Please let me know if you have any doubts in the chat box. Now we'll discuss about the radiological examination. Radiological examination of the breast. In the radiological examination, we discuss in two different modalities, which are the best used and most used in radiological examination of the breast. One thing is, if the patient is less than 40 years, if the woman is less than 40 years, there will be denser breast, more parenchyma. So, which is the modality of choice is ultrasonography. USG is the best modality of choice. If the patient is more than 40 years, which is the best modality? Yes, mammography. X-ray mammography. Okay. So we'll discuss what is the important things and what are the findings that we see in ultrasonography. Ultrasonography, it is usually or it is the primary choice of investigation, primary choice of screening also in less than 40 years. Okay. Next, ultrasonography, it easily differentiate, or it is used to differentiate cystic from solid lesions. Cystic lesions from solid lesions. How the cystic lesions appear? Cystic lesions usually anechoic, and solid lesions will have echoic features or heterogeneous. Okay, if you see any clearly outlined, well defined, let's say like this, well defined solid mass, which is usually mobile, and well defined mobile, and the patient is young. Yes, what is it? Yes, it could be a benign lesion, probably a fibroadenoma. If it is a solid mass with irregular or speculated margins, or poorly defined mass with irregular margins, fixed or non-mobile, it can be fixed or limited mobility. We can't say in a radiological examination it has malignancy. We tell it as suspicious of malignancy. Which is confirmed by histopathological examination. Okay. So ultrasonography is not only for the breast tissue. After diagnosis, if it is malignant, histopathological examination confirms it as malignance, then ultrasonography is also used to screen where? Axilla. To screen the axilla. Yeah. So this is about ultrasonography. Then the mammogram, which is very important. Most of the questions come from the mammogram. Even in UG or PG exams also, it can be a 10-mark question, 5-mark question or multiple choice questions also comes from mammogram. It is the first investigation, first investigation in older women. Investigation of choice or radiological investigation of choice for screening in older women. In older women. Okay. Yes. What is this mammogram? We'll discuss it a bit more. Mammogram. Mammogram machine is similarly like a X-ray machine, but it is very heavy machine wherein the breast tissue is imaged in different angles. What are the views that we use in mammogram? One is craniocaudal view. What is that? Craniocaudal view. Craniocaudal view. So let's say this is the breast. It is imaged from above downwards. This is craniocaudal view. Craniocaudal view. The X-rays are sent from above and received from below. That is craniocaudal view. What is the importance of craniocaudal view? It is best for medial aspect of the breast. It is best for medial aspect of the breast. So inner parts of the breast are best imaged, or if any pathology is there in the upper inner or lower inner part of the breast, the best view we can use is craniocaudal view. Okay. The other views are mediolateral view or oblique. Mediolateral oblique view, which we image. Let's think this as a breast. Here, if the X-ray is just like a camera, we look from above downwards. If we are looking from above downwards, this is craniocaudal view. If we are looking from medial to lateral in an oblique direction towards the axilla, it is mediolateral oblique view. So what is the importance of mediolateral oblique view? It is towards the axilla, so it is best view for axilla and upper outer quadrant. So upper outer quadrant has the most of the parenchyma, breast parenchyma. So it is the most common site for breast cancer or breast lump or breast diseases. So which is best observed in mediolateral oblique view, and also it covers most of the volume of the breast. Okay, so this is about mediolateral oblique view, and there are some special views. These things most of the people we know. What are the special views that are available? One is 90-degree lateral view. 90-degree lateral view, which is also used along the craniocaudal view. These two 90-degree from the lateral, not the medial oblique view. It is 90-degree parallel to the craniocaudal view. Why? Like, see, this is the craniocaudal view. This is the 90-degree lateral view. Let's say this has y-axis and this has x-axis. This is used to point out where the lump is. That is to triangulate the exact location of lesion. 90-degree lateral view along with craniocaudal view is used to triangulate the exact location of the lesion. Next, one more important thing is spot compression view. Spot compression view. It is nothing but a mammography where the breast tissue is compressed breast tissue is compressed. Why it is compressed? To decrease the so if this is the breast, it is compressed. It is compressed between the plates. While when the tissue is compressed, the distance from the emitter and the receiver, the X-ray distance, the distance of the lesion from the emitter will be less. So when the distance is less, the artifacts will be minimized. There will be minimal artifacts, and we have very good resolution of the abnormality. That is about the spot compression view. Okay. Then another newer modalities in the breast. Till now we have X-ray mammogram, which is now developed as digital mammography. Digital mammography, which uses spiral CT images for 3D reconstruction. 3D reconstruction of the breast. What is the uses of this digital mammography or 3D reconstruction or 3D mammography? All are same. 3D mammography. Yes, it allows manipulation or enhancement of the images, enhanced images with better resolution if, and this is very useful in dense breast tissues. Okay. So this is about digital mammography. Where this mammography or X-ray mammography is used? Yes, it is the screening investigation of choice. Screening investigation of choice in older women, that is more than 40 years. Older women. This is radiological and clinical examination. Okay. Important things in the mammogram. What are the findings? What are the findings we see in a mammogram? What are the findings that suggest whether it is benign or whether it is malignant in the mammogram? If we see the mammogram, it can be, that is, benign or malignant lesions. If there is a lump, or a lesion, if it is well circumscribed, or well defined, round or oval, or smooth borders or regular borders, smooth edges or regular borders, then it is benign. If it is irregular in shape, or irregular borders, or ragged edges, or ill-defined lesions, they are usually malignant. Okay. If there is calcification, and those calcifications are large calcifications, also called as macro calcifications, which has bigger one like popcorn calcifications. Where we see popcorn calcification? Anyone? Popcorn calcification? Yes. And in malignancy we see microcalcifications, which can be cluster like, fine or amorphous, or linear, or it can be branching calcifications also. Why this so many types? Yes, because we can Based on this, we grade the mammogram. We grade the mammogram. Then what else? If the breast architecture of the breast, if architecture of the breast is preserved, architecture, that is breast parenchyma and the ligaments of Cooper, everything which holds the breast in place and the architectural design of the breast is preserved, then it is benign. If there is architectural distortion of the architecture of the breast, then it can be malignant. Okay, so this is about benign and malignant findings of the breast in mammogram. Now we see different findings or different calcifications we find in mammogram. That is calcifications, characteristic calcification, which is very, very important in your MCQ questions. One is if the patient is having fibroadenoma. Yes, what type of calcifications we see? Yes, we see popcorn calcifications. We see popcorn calcifications. In case of lobular carcinoma, we see neighboring calcification, surrounding. In case of duct ectasia, what are the it looks as broken needle calcification, broken needle type of calcification. If it is fat necrosis, lead pipe calcification. In fibrocystic disease, we can see teacup calcification. So this is about the calcifications in different mammograms. Then we told based on the architecture and the type of the calcifications and the type of the lesions, whether the borders are irregular, solid, we grade the breast lesions. That grading is called BIRADS, breast imaging, reporting and data system, BIRADS. Okay, breast imaging, reporting and data system. The full form of BIRADS is also previously asked MCQ in one of the NEET PG examinations. A BIRADS scoring, there is a 1 to 6 grades. That is, if it is 1, if it is scored as 1, it is called as negative. This BIRADS scoring is it can be based on the mammography or ultrasonography. It also suggests what to be done, the recommendations, the grade. It tells about the grade and what the assessment is or report, and recommended management. Recommended management. Yes, what it is? Yes, if the BIRADS 1, It is negative. It is negative. Regular annual follow. Regular annual follow. Okay. If it is BIRADS 2, it is benign. Benign. Let's say it can be a fibroadenoma or fibrocystic disease. Anything. Fibroadenoma or traumatic fat necrosis or fibrocystic disease. Anything. If it is benign, it is also no need of any intervention. It can be followed up regularly. Regular annual follow yearly. If it is grade 3, if it is reported as grade 3, it is not malignant, it is probably benign. They are not benign, not malignant, it could be probably benign. The important thing is what is the percentage of malignancy, risk of malignancy or probability of malignancy in these. If it is BIRADS 1, there is 0% chance, 0% being malignancy. If it is BIRADS 2 also 0% being malignancy. If it is BIRADS 3, it is less than 2%. So there is about 1 to 2% chance of malignancy. So we should intensify the follow-up, that is 6 months. 6 months follow-up is advised for BIRADS 3. Okay. Now what is BIRADS 4? What is BIRADS 4? It is suspicious of malignancy. It is suspicious of malignancy. Earlier it was BIRADS 4, which is defined as 2 to 95% chances of malignancy. Now it is divided into 4A, 4B and 4C. 4A, it is 2 to 10% risk of malignancy. Grade B is 10 to 50% risk of malignancy. And grade 3 is more than 50% to 95% of risk of malignancy. What we do for this? For grade 4 BIRADS, we advise biopsy. Remember, biopsy is always incisional or true cut biopsy. It can be incisional or true cut or core needle biopsy. Okay. Now grade 5. What is grade 5? It is highly suspicious of malignancy. Highly suspicious of malignancy, which is more than 95% risk of being malignancy, probability of being malignancy. For this, we do biopsy. Biopsy is must here. For grade 4, we advise biopsy. For grade 5, we do biopsy. For grade 6 is nothing but biopsy proven malignancy. Either by true cut or surgery, it is done. Biopsy proven malignancy. What is the recommended? Further management by surgery or whatever according to the stage. According to the stage, it is treated. Okay. So this is about BIRADS. BIRADS 1 is negative. We regular follow-up for BIRADS 1 and 2. 2 is benign. 3 is probably benign. 6 months follow-up. BIRADS 4 is suspicious of malignancy. 4A, 4B, 4C, 2 to 10%, 10 to 50%, more than 50 to 95%. And BIRADS 5 is highly suspicious of malignancy, and BIRADS 6 is biopsy proven malignancy. So this is about BIRADS staging, grading. Okay. Next, what are the other radiological methods we have? Before going to the pathological examination, we focus another imaging methods which we have. The other methods are magnetic resonance imaging, MRI. MRI is not routinely used. Not routinely used in breast diseases. Where these MRI are used? MRI are used indications of MRI in breast disease. Where we use one thing for screening. You can tell for screening, we talked about less than 40 years, we use ultrasonography or whatever, more than 40 years mammography. Yes, for this screening, MRI is used only in case of high risk patients, high risk individuals. Who are those high risk individuals? Who has lifetime cancer risk? Lifetime cancer risk is more than 20 to 25%. Yeah, how this lifetime cancer risk is evaluated? Based on different risk assessment models, models risk assessment models like Gale model. We'll talk about this Gale model and BRCA Pro model, class model. We'll talk about this a bit later. This is not the discussion. We are talking about indications of MRI. One is screening in high risk, more than 20 to 25% lifetime risk. The next one is the patients with breast implants. Patients with breast implants. Patients with breast implants. Next thing is in case of lobular cancer. In case of lobular cancer, to look for multicentricity or multifocality. What is multicentricity or multifocality? Yes, multicentricity is if there is multiple diseases in a single quadrant and the distance should be more than 2 centimeter. If it is more than 2 centimeter, then it is called multicentric tumor, which is more common in lobular cancer, and also multifocalities in different quadrants. So to differentiate between multicentricity and multifocality, in case of lobular cancer, MRI is used. What is the other thing? What are the other indications? In case of surgery, post-surgical patient, post-surgery, we have scar. So in case of scars, we use MRI to differentiate it from recurrence. It can be multiple collagen deposits or fibrosis, which look like a recurrence. For to differentiate the recurrence from hypertrophic scar or the scar tissue, we use magnetic resonance imaging. In case of irradiation, post-radiation, if the patient has received chest wall radiation and there is lump in the breast, in such cases, to differentiate between radiation-induced artifacts, we use MRI. And in case of, which is an important indication, high grade DCIS. High grade DCIS on TrueCut or investigations, it came as a ductal carcinoma in situ with high grade. In such cases, we advise MRI. And the other important things are two things where no palpable lump, but there is no palpable lump, but there is axillary node. In this case, we use MRI and no palpable lump with Paget's disease. In these two conditions, we use MRI of the breast. Okay. So what are the important? There are two important things in the MRI findings. One important finding is in case of implants, which is usually silicone implants, which undergo rupture, they form some signs like linguine sign, which is seen on MRI, which is intracapsular rupture of implant. Intracapsular rupture of implant. See, this is the MRI of the breast. In case MRI of the breast, where this is the first one. This is the in pre-contrast tissue. You can see here the breast which has fat, which is highly intense lesion, and here this lesion has low intensity in pre-contrast, which takes up contrast in gadolinium contrast image. So to differentiate this fat from contrast, we do subtraction imaging. We subtract the fat tissue. We subtract the fat tissue from the MRI. That is subtraction image, which shows the fat is subtracted and the tissue which is abnormal is highlighted. This is subtraction image showing a malignant lesion in the breast. These are MRI images. And linguine sign. See, can you see this? Linguine sign, intracapsular rupture. There is falling of this implant. This is called linguine sign. The similar sign when it is seen on ultrasonography, it is seen. Ultrasonography is 2D imaging, which is seen from above downwards. So it is seen as step ladder. See here, it is seen as step ladder. So this is called step ladder sign. It is called as step ladder sign in ultrasonography. So it is step ladder sign. It is intracapsular rupture of silicone implant on USG. It is called step ladder sign. Okay. The other imaging modality used in breast important is PET-CT, positron emission tomography. PET with CT both. It is two imaging. PET is FDG, fluorodeoxyglucose, is ingested. It is based on whether any tissue in the body is hypermetabolism, where the tissue is undergoing hypermetabolism. In cancer, we know that cancer cells have immortality and uncontrolled division, which shows highly metabolically active. High metabolism will be there. So they need more glucose. So when FDG is given, these are taken up by these cancer cells more avidly, and when they are detected by gamma camera. They emit photons or positrons, and they are captured by special gamma cameras. That is photon emission tomography. When this imaging, how we see if there is any, let's say this is a head, body. If there is any increase in signals in the brain, it is normal. But in case of any malignancy, there is intense where there is malignant lesions in case of breast and axilla. But we don't know, we can't see the anatomical location or anatomical delineation in PET. So it is combined with computed tomography, that is CT. So simultaneous CT images helps us to locate and delineate the anatomical points. So that is PET CT. The indications in CA breast, it is indicated in all locally advanced breast cancers. Locally advanced breast cancers. I will talk about staging in malignancy module. And if the malignancy is having high mitosis or high mitotic index, high mitotic index, or if you are suspecting any metastasis, suspected metastasis. Okay, in these conditions you will carry out PET CT. How the PET CT is seen? Yes, it will be like this. It is a CT which shows, can you see here? Yeah, this is the axilla, sorry, this is the breast and this is the axilla. Breast, there is high intensity. See, this is the normal and this is the lesion. This is the lesion and this is one more lesion in the axilla which shows the nodes. This is in the coronal section. Similarly, this is the this is the breast tissue and this is in the axilla. Okay, so this is PET CT. So this is about imaging. This is about imaging of the breast. What is the third part of the triple assessment? It is pathological examination. Yesterday I told, yeah, to again let it be. Remember, FNAC is not used. Is not used in breast. Where it is used? Yes, FNAC is useful only in recurrence lesions to know whether it is recurrent. Okay, the diagnostic or pathological investigation of choice is core needle biopsy. Core needle biopsy. Core needle biopsy, which is also called as true cut biopsy. Okay, core needle biopsy in the new 28th edition. New 28th edition, they have mentioned the sizes of the needles for breast tissue and also for the axilla, which can be a potential MCQ for your next or NEET PG. So that is in breast tissue. For breast, it is 14 gauge needle is used. For axilla, 18 gauge needle is used. Okay. The another method of biopsy is recently used, that is vacuum assisted biopsy. Vacuum assisted breast biopsy. It is also called as large core vacuum assisted biopsy. We use 8 to 11 gauge needles. This is also has extensive utilization as diagnostic and also therapeutic. Diagnostic in cases of malignancy, as we discussed, as large core vacuum assisted biopsy, and therapeutic in small benign lesions like fibroadenoma, where a small 2 mm incision is taken and the whole fibroadenoma is aspirated using vacuum. So this is about triple assessment. This is about triple assessment. So any doubts in the triple assessment? Anyone? Yes. Let's revise what all we saw today. Yes, the breast tissue. Yes, it is extending superiorly from the second rib to the sixth rib, medially from the lateral border of the sternum to the anterior axillary line or mid axillary line. The functional unit is terminal duct lobular unit, and the ligaments of Cooper, which is attached to the undersurface of the dermis. It's the undersurface of the dermis to the pectoral fascia deeply. And the two important muscles which are updated in the newer edition of Bailey, that is Sapis muscles, which helps in nipple erection, and Meyerhold's muscle, which helps in nipple retraction. The arterial supply and Burke's levels based on pectoralis minor, which is medial to the pectoralis minor is level 3 and lateral to the pectoralis major is level 1, and the behind the pectoralis minor is level 2. It is pectoralis minor, not major, remember this. Okay, and the presentation, various nipple discharges in case of serous, it is in it can be pregnancy, puberty, malignancy, or duct ectasia. In case of blood, in single duct, if blood is coming from the single duct of the nipple areolar complex, it can be duct papilloma. If it is multiple duct, it can be malignancy. Triple assessment, which is combination of clinical, radiological, and pathological. If the patient is less than 40 years, we use ultrasonography. If the patient is more than 40 years, we use mammography. And pathology, core needle biopsy is the investigation of choice for pathological examination. Combine these three, it is about 100% accuracy. Diagnostic accuracy is about 99.9% if all these three are combined. And I already told the clinical, various methods of clinical examination. This is vertical stripes method, and also you can use horizontal stripes method also. This is circular method which we regularly you see in the wards. The best method is dial clock method, that is 3 cm from the 12 o'clock which is interposed between the next 3 cm circle. So after 12 o'clock, 1 o'clock, next 3 o'clock, and it is continued in the clockwise direction, which is the best method. And ultrasonography and mammogram we discussed. These are the mammographic images of a normal breast. This is medial lateral. It is medial to the lateral view, and this is above downwards. This is cranial, and this is caudal, craniocaudal view. So this is medial lateral oblique view, where we can see axilla. We have, see, this is the axilla. Axilla and upper outer quadrant is best seen in medial lateral view, oblique view, and the inner quadrants are best seen in craniocaudal view. Okay, we saw the differences between the mammographic findings in benign breast diseases and malignant breast diseases, and these are the malignant breast disease on mammography. Various can you see here, there are the mass which is irregular. This is irregular mass is there, and this, can you see here, fine small amorphous powder like calcifications. So these are all features of microcalcifications, or features of malignant disease. Okay, we saw Bairad's grading. 1 is negative with regular annual follow-up, 2 is benign, again annual follow-up, 3 is probably benign, it is less than 2% chances, 6 monthly follow-up. Grade 4 is divided into 4A, 4B, and 4C, which is 2 to 95%. We advise biopsy. Highly suspicious of malignancy, which is grade 5, we do biopsy. Biopsy means core needle biopsy. And for grade 6, which is already biopsy proven, MRI we saw for high risk patients where the lifetime cancer is 20 to 25%, and in case of breast implants, lobular cancer, post surgery to differentiate it from scar and recurrence, post irradiation, high grade DCIS, axillary node metastasis without primary, and Paget's disease without palpable primary. Okay, we saw these images also. Stepladder sign and Linguini sign. Stepladder sign is on USG. and linguine sign is on MRI. Okay, PET CT images we saw the primary and the axillary nodes which are FDG positive, which is indicated in all locally advanced breast cancers, and high mitotic index Ki67 index is nothing but mitotic index, and any early breast cancer or any breast cancer which you have suspicion of metastasis but there is no evident clinical metastasis. Pathological examination, core needle biopsy is the investigation of choice. Breast tissue we use 14 gauge, axillary we use 18 gauge, and 8 to 11 gauge for large volume core needle biopsy. So this is about surgical anatomy and investigations. We'll talk about carcinoma of breast in the next class. Any questions, please let me know. Yes, thank you.